Hi there, my name is Emma. I'm a PharmD candidate. This is a MedEd 101 production and the last video in our series that's discussing potential clinical guideline updates. These are formatted sort of as a mini journal club where we're going to discuss some background and then discuss a paper that was recently published. So this video is going to cover antiplatelets and DOAC use in patients who have ASCVD and atrial fibrillation. So the objectives of this presentation, we're going to cover mechanism, so review antiplatelet and DOAC mechanisms of action. We're going to talk about indications and reasonings for dual antithrombotic therapy. We're going to describe some background studies leading to the current research, and then discuss the major findings of the EPIC-CAD trial and potential influence on practice. So what are the mechanisms? So as you may already be aware, aspirin and P2Y12 inhibitors prevent platelet aggregation. P2Y12 inhibitors irreversibly block P2Y12, versus aspirin inhibits both prostaglandin synthesis and platelet aggregation through COX inactivation. DOACs, on the other hand, are oral anticoagulants that inhibit factor Xa, which decrease thrombin generation and thrombus formation. So what are the indications? So again, as you may already be aware, antiplatelets are for primary prevention of CAD, stable ischemic heart disease, and secondary prevention of stroke after TIA or non-cardioembolic stroke. DOACs, on the other hand, are for AFib prophylaxis, DVT prophylaxis or treatment, or PE prophylaxis or treatment. So when do we use them both? So if a patient has a certain device, like a left ventricular assist device, then it's indicated to use both of those antithrombotics. Or if they have non-valvular AFib or VTE, and they experience an ACS event and or undergo a PCI, then the patient should be prescribed both. So what do the background studies say? So we're going to discuss three different background studies. The first one looked at aspirin and DOAC use within atrial fibrillation. Researchers noticed an increased use in prior MI, CAD, vascular disease, and diabetes. And the major finding of this study was an increased risk of bleeding with little benefit with the use of both. The second study looks at aspirin and DOAC with no indication. So researchers were finding that the addition of aspirin to a DOAC with no clear indication was somewhat common, and these patients experienced increased bleeding events without improvement in thrombus. And then our most recent study, aside from the next one we're going to discuss, looks at adverse events with aspirin and DOAC use. So they found that a third of patients with AFib and or VTE on DOAC also received aspirin without a clear indication. So they found that concurrent use increased bleeding and hospitalizations in this patient group. So in our current study, we're going to look at DOACs plus antithrombotics in AFib with CAD. So we will discuss the EPIC-CAD study. The main objective of this study was to compare edoxaban monotherapy with dual antithrombotic therapy as long-term antithrombotic treatment in patients with AFib and stable CAD. So these patients were at a high risk of thromboembolism with a CHA2DS2-VASc score of 2 or greater, with atrial fibrillation and stable acute coronary syndrome. This was an open-label, adjudication-masked, randomized trial with 18 different sites in South Korea. And the primary outcome was net adverse clinical events. So that was a composite of death from any cause, MI, stroke, systemic embolism, unplanned urgent revascularization, or major or clinically relevant non-major bleeding at 12 months. And then the two patient groups, first was the edoxaban monotherapy with 524 patients, or the patients were in the edoxaban plus aspirin or P2Y12 inhibitor group at 516 patients. So what were the results and conclusions from this study? So they found that the risk of primary outcome was significantly lower in the edoxaban monotherapy group, and there was a lower incidence of major or non-major bleeding. And the risk of major ischemic events was similar in each group. However, to note, there is a risk of bias due to net adverse events being the primary outcome, so this could favor a less potent antithrombotic strategy. So will this change practice? As you might suspect, since there was a little bit of bias with this study, I would say that this probably won't change practice yet. Additionally, this trial was conducted in South Korea, and as you may be aware, if we compare that to the Western population, there is definite propensities for bleeding complications and ischemic events. So it might be more difficult to translate these findings to a Western audience. Overall, the risk of bleeding is higher with the combination of DOAC and antiplatelets, as you saw with our prior studies, and usually there's no added benefit unless it's specifically indicated. So, all this to say, sometimes less is more when it comes to anticoagulant therapy. So here are the references I used for this presentation. And thank you so much for listening. If you have any questions or comments, please comment them down below. And thank you for your time.